Hello doctors, welcome back to Pharmacology. Myself Dr. PADMANABHA TS. I'm going to teach you about some of the very important topics that needs to be revised for Fmge pharmacology MCQs. So let us take up the very important MCQs which has been asked multiple times in your exams, and this concept has to be understood for solving many other similar MCQs. So the first MCQ is, you can see that a new drug application for introduction of a new drug in the market is filed after which phase of clinical trial? Which phase of clinical trial? So your answer is, so they're asking a new drug application. So when do we apply for new drug application? Okay, fine. Hope all of you have got the right answer. It is after phase 3. So just to understand the concept of the clinical trial, first we will be doing the preclinical study. So once the candidate molecules are showing the beneficial efficacy, it will be taken and the application will be given for new or the investigational drug application. IND is for investigational drug. So following that, you'll be taken into clinical trials. So what happens in case of clinical trials? There are four phases of clinical trials mainly. It is phase 1, phase 2, phase 3, and phase 4. So investigational drug application is applied before is applied just before the phase 1, just before the phase 1. Whereas the new drug application will be done here just before going to phase 4. New drug application will be applied to the regulatory agencies. So once the new drug application is approved, the drug will be marketed. That is phase 4 clinical trial. So just to recapitulate, phase 1 is done in healthy human volunteers. Whereas phase 2, 3 and 4 are usually done on patients. So this will involve the small number of patients, around 50 to probably around 100 or till 500. This will include from 500 to 5000. Phase 3. So phase 2 is done at a single center, whereas phase 3 is done at the multiple center. And basically what you are going to see in case of phase 1 is the you're going to see the safety and tolerability. So you're going to check for the maximum tolerable dose. So basically you're checking the dosing range in case of the phase 1 clinical trial. Whereas in phase 2, along with the safety, that is phase 2 will be done in patients, first in the patient. So here in phase 2 you're going to check for the let us change the color, check for the efficacy. So phase 2 is also called as therapeutic efficacy or therapeutic exploratory stage. Whereas in case of phase 3, you're going to confirm the efficacy in larger population. So you're going to confirm the efficacy in larger population. And phase 4 is nothing but the post-marketing surveillance to check for any rare side effects or any untoward consequences. And one more thing you should remember is phase 1 and phase 4. Please remember, phase 1 and phase 4, they are open label study, whereas phase 2, 3, they are usually randomized blinded study. So usually phase 3 will be double blinded study, whereas in case of phase 2 it can be an open label or a blinded study. Double blinded means both the investigator and patient will not be knowing what they are receiving. So this is all about the new drug application. Just remember, if they ask about the investigational new drug application is applied just before the phase 1, whereas the new drug application will be applied after the phase 3. So next, moving on to the second question. So alkalinization of urine is done for treatment. Alkalinization of urine, please remember it is urine, done for treatment of poisoning due to which of this drug? Poisoning. So usually as a concept we should remember is alkalinization is done for urine alkalinization and acidification. So urine alkalinization is done in case of please remember it is weak acidic drug poison, where alkalinization will lead to increase in the ionized forms. That means to say ionized forms are more water soluble. So thus it can be easily thus it can be easily excreted. Whereas on the other hand, acidification is done for weak basic drugs. Again the same concept here also, it will going to increase the ionized forms, and thus it will going to increase the water soluble forms, and it gets easily excreted 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 excreted. So what are the substances that will be used for please remember what are the substances that will be used for alkalization. Please remember, for alkalization you will be using substances such as sodium bicarbonate or sodium citrate. Whereas for acidification you will be using ammonium chloride. You can use vitamin C, that is ascorbic acid ascorbic acid. And also you can use cranberry juice. And here for alkalization, one more substance you can add is the carbonic anhydrase inhibitor. Carbonic anhydrase inhibitors. So this was about the urine alkalization and acidification for increasing excretion of poisonous drugs. So here the answer will be alkalization of urine is done for weak acids. So next, moving on to the third concept, that is the fraction of administered drug that reaches the systemic circulation in an unchanged form. So it is known as, it is a direct question. Please remember, this is a definition of the bioavailability. So what is the definition of pharmacovigilance? It can be remembered in the form of DAUP. Pharmacovigilance stands for, it is a art as well as science that deals with the detection, assessment, understanding and prevention of adverse drug reactions. So what do you understand by bioequivalence? So whenever you choose a two drug, let us say drug A and drug B, which are having the same formulation, same chemical structure, but they are from the different manufacturers. So for example, A is a brand drug and B is a generic drug. To show this generic drug as a same plasma concentration or biological efficacy, We're going to compare with the standard drug. So whenever we compare the standard plasma bioavailability or the plasma concentration, so their difference should not be more than 20%. Then only we say that two drugs are said to be bioequivalent in nature. So the two drug will not have a major difference with respect to the plasma concentration that they will going to attain following the administration. So next is the pharmacodynamics. Pharmacodynamic, it tells about what drug does to the body. So what is the definition of pharmacokinetics then? So it is the what body does to the drug. It mainly deals with the A D M E, that is the absorption, distribution, metabolism, and the excretion. So these definitions you should remember, but here the answer will be the bioavailability. Bioavailability is the fraction of administered drug that reaches the systemic circulation in an unchanged form. So usually it is represented in the form of, one more question they can ask is the formula. Formula, it is represented as F. So it is area under curve for for oral divided by area under the curve for IV route. So this is the formula for bioavailability. So for IV we have got 100% bioavailability, whereas for all other routes of administration the bioavailability will be less than 100%. Okay, next moving on to the next question, that is to find a therapeutic index of the drug. So which of the option is correct here? So the therapeutic index will tells you regarding the safety profile. So how do you going to check for safety profile? What is the effective dose when you draw a graph? So this is the concentration and this is the efficacy. So if you plot a graph, suppose for drug A, the minimal effective dose will be, let us draw with the green color. Minimum effective dose will be this. For example, say it is 50. And the lethal dose will be 100. So this is the gap in between the effective dose and the lethal dose is called as the therapeutic index, or sometimes they mention it as the therapeutic window. So it is represented by, you can remember by the formula, therapeutic index style. So Ti is equal to lethal dose 50% and effective dose 50%. So what do you understand by 50%? It is the dose at which 50% of the animals will die. So lethal dose is usually given for the animals, whereas in humans we talk about lethal dose in terms of toxicity. So it is the LD stands for lethal dose. It is the drug at which 50% of the animals will die. What is the effective dose? ED stands for effective dose. 50 means it is the dose of a drug at which 50% of the individuals have a beneficial response. So here the correct answer will be third option, LD 50 by ED 50. It is 50%. It is 50%, not just a 50 number. It is 50%. So next, coming to the log dose response curve. Log dose response curve. So let us draw a graph here. Okay. This is y-axis. This is x-axis. So x-axis will talk about the concentration and y-axis will talk about the efficacy. So basically concentration means we are talking about the potency here. Potency. The height along the y-axis will tell us about the efficacy, maximum efficacy. Suppose let us take one drug. So this is a drug A. This is the drug A. Next we'll take one more drug. This is a drug B. Next. This is drug C. Let us draw one more graph. This is drug D. So this concept you need to understand. So if you understand this concept, you will be able to answer most of the questions from log dose response curve. So let us compare. So x-axis tells about the potency and y-axis tells about the efficacy. So when we compare a A and B, so when we check the x-axis, so which has got more potency? The drug A has got more potency because it is producing these response at the minimal dose, whereas the dose required to produce the same efficacy that of the A with B is it requires more dose. So A is more potent than the B. So let us write A is more potent than B. So we are talking about the potency. A is more potent than B. So let us take the potency with respect to the C. So when you take a comparison of potency with the drug C, A is more potent than B, but B is more potent than C. And here also one more thing is the drug D is more potent than the drug C. When we talk about the efficacy is measured in terms of the height of the response. Here which of the drug has got more height? So it is A and B. So what we can confirm from this, A and B are equally efficacious, but potency wise A is more potent than B. So when we compare A, B and C, A is equal to B, but A and B are more efficacious than C and D. Here you can see C and D has got similar efficacy, but the D is more potent than the C. And one more thing you should remember is drug B is a competitive antagonist. Please remember drug B is a competitive antagonist. Drug B is a competitive antagonist. So to produce the similar response to that of A that is the agonist. So you're going to increase the dose. You're increasing the dose here, potency. So what about drug D? Drug D is a non-competitive antagonist. Although they are having both similar potency, even if you are increasing the dose, the efficacy is decreased. So you can see the height of the curve of drug D as well as the drug A. So this will tells you about the efficacy. So this distance will tells you about the efficacy. So this general concept you should remember under this log dose response curve. Next, moving on to the next question, that is the anti-malarial drug which is having highest risk of hemolysis in patient with G6PD deficiency. So usually the options which are provided for this question, all of the drugs can cause the hemolysis in patient with G6PD deficiency. But here the clue is they're asking about the anti-malarial drug. So this dapsone is used mainly in case of leprosy. So this is ruled out. The remaining three they are all used in malaria. So here please remember the highest risk will be seen with the primaquine. This is followed by the chloroquine and next is the quinine. So this is the order in which hemolysis will be caused. So the answer for this question will be the highest risk of hemolysis is seen in patient with G6PD deficiency is with primaquine. Next, which of the following drug causes Ebstein's anomaly? So they're asking about the Epstein anomaly, that is the teratogenicity. So here the carbimazole will cause, please remember carbimazole is an antithyroid drug, it will cause choanal atresia, whereas tetracycline will going to cause teeth and bone deformity, whereas the fluoroquinolones will cause damage to the cartilage as well as the tendon. It causes tendon, whereas it is the lithium which will going to cause Epstein anomaly, which is basically it is the cardiovascular defect. So the answer here will be the lithium. So carbimazole is an antithyroid drug which causes choanal atresia. Tetracycline, they cause teeth and bone deformity, especially in case of children's. Fluoroquinolones will cause cartilage and tendinitis, whereas lithium will cause Epstein anomaly, that is CVS malformation. Next, moving on to the next question, that is which teratogenic effect? Please remember which teratogenic effect is produced by thalidomide. Thalidomide was previously used as an anti-emetic drug in case of pregnancy. So because of this teratogenic effect, it was discontinued. So thalidomide will cause what? So it is the direct question you should remember. Thalidomide will cause phocomelia. It is like seal-like limb deformity. So here the answer will be the phocomelia. Phocomelia. So other options, let us see what are all the drugs which can cause the other teratogenic effect. Other teratogenic effect. Please remember nasal hypoplasia is caused by warfarin. Whereas gray baby syndrome is caused by chloramphenicol. Whereas Redman syndrome is caused by vancomycin. And please remember the Blumen syndrome is caused by amiodarone. So phocomelia is caused by thalidomide. Nasal hypoplasia is caused by warfarin. Gray baby syndrome is caused by chloramphenicol. Redman syndrome is caused by vancomycin. And Blumen syndrome is caused by amiodarone. Next, moving on to the next question, that is a topical atropine is contraindicated. Topical atropine is contraindicated in. As you know that atropine is a anticholinergic agent. Anticholinergic agent. So which is the absolute contraindication here? Absolute contraindication. You cannot use in case of the acute congestive glaucoma. It will going to further precipitate the increase in intraocular pressure and the patient may go for blindness. So you need to avoid the use of atropine. So in all other, in corneal ulcer, in malignant glaucoma and acute anterior uveitis. So these are the three conditions where this anticholinergic drug will provide a relief. They provide a relief from pain because of their anticholinergic action. Where they are going to mainly block the M3 receptors. M3 receptors will be blocked. So next, moving on to the question number 10, that is the drug of choice for treatment of scorpion sting. Again, this is a direct question. Please remember, it is the scorpion sting bite. The drug of choice will be prozozin, which is a alpha blocker. So where do we use the other drug? Atropine is a drug of choice in case of OP compound poisoning. So please remember, it is used in the case of OP compound poisoning. So neostigmine, where it is used? Neostigmine, it is used in case of myasthenia gravis. So where do you use pralidoxime? Pralidoxime are the enzyme reactivators. Please remember, pralidoximes are the enzyme reactivators which has been used along with the atropine in case of OP compound poisoning. Not in case of carbamate poisoning, because the enzyme, this carbamate will going to occupy both the sites which are present on the colon esterase. Thereby there will be no site which is empty which can bind to the enzyme reactivator, that is pralidoxime. Okay, fine. We have discussed a very important 10 MCQs along with the concept. In the upcoming revision session, let us take some more important MCQs as well as the concept related to those MCQs, so that you'll be able to apply those concepts and solve lot many questions related to those concepts. Thank you. Hope you have enjoyed it. Thank you.